fantastic session that I'm super excited about with Dr. Hyman Scott and Dr. Albert Liu. I have the honor of introducing them. Dr. Scott is the Clinical Research Medical Director at Bridge HIV within San Francisco Department of Public Health and is an expert on the epidemiology of HIV-related racial and ethnic disparities among men who have sex with men and developing and evaluating interventions to reduce these disparities. And Dr. Albert Liu is and now my intro actually just didn't load, but you are the director of HIV prevention intervention studies. Is that correct? Did I get that right? Thereabouts? Yeah. And also is a renowned expert on HIV prevention, conducting trials on the safety, effectiveness of PrEP, as well as real world implementation of PrEP across different treatment settings. So I am thrilled to welcome them. They have a really fantastic case-based session for us and have kindly agreed to take questions in between the cases. So as you think of them, feel free to raise your hand after we're done with each case or put them in the chat, and I'll hand it over to Dr. Scott. Thank you.
Good morning, everyone. So we're excited to talk about PrEP as usual. So I'm going to start off with some cases, and then I'm going to hand it over to Al. So we're going to focus on some priority populations for this case-based discussion. So these are our disclosures. And this is the roadmap for what we're going to talk about today. So we're going to go through a PrEP start, restart, CAB, LA, and then talk a little bit about PrEP and pregnancy as well. So as we focus on priority populations, we always come back to the question, like, who are our priority populations? And so there's some very sobering data that has come out from CDC around who is using PrEP that could benefit from PrEP. And as someone who focused on disparities, these are always the graphs I hate to see because they document how bad things are already and how much worse they're becoming. So these are by race, ethnicity, and you can see that about 94% of individuals who are white who could benefit are currently using PrEP or received a PrEP prescription, whereas it's very low, under 25% for Hispanic, Latino, and 13% for Black African Americans, who combined make up 60% of the HIV infections in the United States. So we are missing the mark, to say the least. There's very bad data on gender. So these are the data for sex at birth in the United States between 2019 and 2022. And you can see that there's been a very slight increase among individuals assigned female at birth in PrEP prescriptions, and a sort of increasing proportion among people assigned male sex at birth. There are some other data that we've compiled that sort of give us a sense of what it is for transgender women and transgender men. So about a third of transgender women have received PrEP prescriptions based on some data that's a little bit older than the data that is present from CDC, and a slightly lower proportion for transgender men have used PrEP. And this is in the last year. So, it's a variable in the way that these are reported. Locally, we also try to track this, and this is a slide that Al put together that looks at the multiple populations that we try to focus on for our work. And so these come from a variety of sources that you can see at the bottom. And I think the most important thing is to look at the relational proportions for each of the graphs with the colors. So you can see in San Francisco, we have a slightly smaller disparity. This does vary depending on which clinical site you're at. But we have a slightly higher proportion of Black and Latinx individuals than we've seen nationally. We're still doing terribly for cisgender women compared to men who have sex with men. There's also a lower proportion among, here's my pointer, among younger people. And then individuals who are unhoused is also quite low. So as we look at our epi reports and see where we're seeing new HIV infections, I think we are seeing that these are gaps that are probably driving our epidemiology locally, and have been a focus for a lot of our work, in particular for our getting to zero. So now that we've introduced some of the gaps in where places we will have for priority populations, we want to get into some cases, and feel free to interrupt and ask questions. There's some audience response as well as we go through this. So this is the first case. So this is a 23-year-old transgender woman who's interested in starting PrEP for the first time. She's on injectable estradiol for gender-affirming hormone therapy, or GAT. And she's had gluteal fillers as part of a gender-affirming procedure that she had 2 years ago. She's researched PrEP, and she actually wants on-demand if possible. She has occasional sex partners and doesn't really want to take a pill every day if she doesn't have to. She has receptive and insertive anal sex with cisgender men and transgender men, and insertive vaginal sex with transgender women. What options would you offer her? So would you offer daily oral PrEP with TDF-FTC or TAF-FTC, on-demand PrEP with TDF-FTC, injectable PrEP with CAB-LA, either of the oral options or any of the options above? So Joe, do I go forward to? Okay. Oh. So give folks a chance to respond. All right, so looks like we've settled out at about a third of folks would say they would give her any of the options. No one wants to offer daily oral PrEP, interestingly, alone. And so about a quarter on-demand injectable PrEP, and then any of the oral options. All right. So we just like to review the CDC's updated guidance, which has really been helpful in 2021, which essentially says that everyone should be offered PrEP. And if they ask for PrEP, they should receive PrEP. You shouldn't even actually probably ask any other questions other than to understand what PrEP options they might be useful for them. So these are some of the different PrEP options, and these are some of the populations for whom these might be useful. And as you can see, daily oral TDF-FTC is available for anyone, except for those who have a creatinine clearance less than 60. And CAB-LA is also for everyone except people who inject drugs, where we don't have any data to support that use. This is a slide from the IAS USA recommendations that sort of outline some of the populations based on transmission risk, and the different options that are available for individuals, cisgender men and women, transgender women, and transgender men. And my general approach is the best PrEP regimen is the one that the patient will use. Regardless of some of the caveats to different regimens, efficacy is not the only factor that is consideration in selecting PrEP. So we actually have the most data for daily oral TDF-FTC for individuals. And I'm gonna go through some data on drug-drug interactions with GAT. But providing this person-centered care and shared decision-making is really important for us initiating PrEP and helping people stay on PrEP. A lot of the data for persistence, so people who start PrEP and then stop later, is actually quite poor. Even in our Strut clinic, our persistence is in the 30s after 6 months. And we're, one of the places that has a lot of resources for individuals to stay on PrEP. So one of the questions that comes up a lot for individual transgender women in particular is around drug-drug interactions with gender-affirming hormone therapy. And there's a lot of work that went into understanding whether or not there was interactions with PrEP and particularly estrogens. And the summary of those data is that the TDF-FTC does not alter estrogen or testosterone levels. There have been several studies, and there have been no evidence of interactions observed for CAB-LA. And there's a cautionary reference to on-demand PrEP, which was a preference for this case for this woman, this trans woman. And it's because there does appear to be a slightly lower tenofovir levels when individuals are using estrogen. This is modest and is actually within the range that we see with fasting in fed states. So when I counsel my trans women who are on gender-affirming hormone therapy, I actually just counsel them to take it with food, because that will actually increase levels at about the same proportion that they're decreased by estrogen. And so it gives trans women an option that they might desire to help them stay on PrEP if that's the one that they choose. So our key takeaways are that we should offer all the PrEP options that may be appropriate. It has to be an authentic choice. If we have PrEP options that we actually can't support, like CAB-LA, and not being able to get it approved by insurance, and it's not actually a real choice. And then center our patients' preferences and what they want to use, that we do offer the options for on-demand PrEP for individuals who are on gender-affirming hormone therapy. All right, I'm going to shift to comorbidities, which is something we see a lot in our clinics. So this is actually a case that we saw recently. So this is a 47-year-old man who has sex with men in establishing care. He has a history of hypertension, diabetes, and hyperlipidemia. His creatinine clearance is 89. He's been on TDF-FTC before and stopped 2 years ago after he lost insurance. And he is interested in restarting oral PrEP as he doesn't like needles. He has heard of newer PrEP pill is safer for the kidneys. And what option would you offer? So would you offer one daily TAF-FTC, daily TDF-FTC, on-demand TDF-FTC, injectable CAB-LA, or daily TDF-FTC or on-demand? All right, so you have about a quarter of folks would offer daily TAF-FTC, 14% injectable, and about 60% would offer TDF-FTC daily or on demand. All right, so this slide probably looks familiar. This is a slide we actually still use to support people making a decision between TDF-FTC. Sort of summarizes from Julie Marcus, was posted on Twitter after TAF-FTC was approved, sort of outlined some of the effectiveness, safety, and some of the concerns, particularly around lipids and body weight that are different between these two products. So the reason that I wanted to highlight this case is because there was some new data that was published in JAMA that looked at a retrospective cohort of EHR data from Kaiser in Southern California between 2019 and 2022 that included about 6,800 patients and evaluated incidence in hypertension and statin initiation after 2 years of PrEP initiation. And in the study, they actually saw that there was an increased hyperlipidemia risk that required statin treatment for individuals who were on TAF-FTC compared to those who were on TDF-FTC. And you could see, that the odds ratio was 2.3 for all. And then when they adjusted for, looked at people over age 40, it was even higher. And so we also looked at hypertension risk. And again, they saw that when you looked at the different strata for hypertension among all individuals, you saw an increased risk of hypertension among individuals who are on TAF-FTC compared to those who are on TDF-FTC. And when we've looked in many of the clinical sites that have made these switches from TDF-FTC to TAF-FTC, there's been very little clinical rationale for that. In terms of creatinine clearance or intolerance. And so I think that these data are raising questions around other potential considerations in our patients who have comorbidities and might be able to tolerate TDF-FTC. And there might be additional risks associated with switching to TAF-FTC. So the key takeaways for this were that we've seen lower declines in creatinine clearance and bone mineral density with TAF-FTC compared to TDF-FTC. However, the clinical significance of that is questionable, and that we have these new data that are suggesting that there might be an increased risk of other comorbidities that are worsened with switch from TDF or use of TAF-FTC over TDF-FTC. So we really are cautious in making switches from TDF-FTC to TAF-FTC for PrEP in general, and I think that these data give us a little bit more pause. So I'm going to turn it over to Al to talk about the next set of cases. So our general approach is so the question was how do we the question was how do we approach trans women who have gluteal fillers? So there's it's heterogeneous in terms of where the fillers are, what the fillers are, and how they may or may not impact the injection. So what we do is an exam to determine if we feel comfortable or safe to do the injection. And then there's some imaging you can do potentially with ultrasound as well to see where they are. But if you have to go through one of those fillers, these are not always like medical procedures done in a medical office. So you want to be very careful. So we don't do that. There are some data that are looking at potentially thigh injections. The tolerability in those studies is actually, not as good as the tolerability for gluteal injections. But if it's between no injection or thigh injection, that's a different sort of choice that people would be making. But that's generally how we approach it. So we don't, it's not an absolute contraindication, but it is something that we have to evaluate pretty closely.
I just was curious about the Descovy data. Did they, and they looked at above 40, but what about when they then looked at below 40? Because for a lot of folks, again, trying 211, they might want to reduce the risk of the bone, and renal may not have the same risk of hypertension. Did that then pan out? I didn't see in those charts if below 40 there wasn't an increased risk.
If there was an increased risk
of hypertension and hyperlipidemia, because we saw all comers, and then it really seemed to be mostly concentrated in people over 40. Did they in the paper then look and say, well, if you're under 40, was there an increase of hypertension and hyperlipidemia?
Yeah, I don't think there was under 40 because we also don't have that sort of that same level of risk of developing hypertension in that age group. So, and that is a large proportion of those who are on PrEP are under the age of 40. So that's an excellent point.
Yeah.
Any other questions? Great. Thank you.
Okay. All right. All yours.
Okay, thanks. Thanks, Hyman. So let's move on to case 3. This is a 34-year-old transgender man who was previously on oral TDF-FTC, had severe nausea and vomiting while taking it, so discontinued. And then a little while later, CAB LA became available, was interested in injectable PrEP. He had Medi-Cal insurance and was able to start CAB LA, tolerated his first and second injections well. However, when it comes time for his third injection, the medication doesn't actually arrive in the clinic. And so you call the pharmacy trying to figure out what happens. And it turns out that his Medi-Cal is no longer active. And then after further investigation, it turns out the Medi-Cal coverage has ended. His new insurance will not be active for at least another month. So in this insurance gap situation, what would you do next? Would you start oral TDF-FTC while investigating coverage, start oral TAF-FTC while investigating coverage, start oral CAB while investigating coverage, investigate coverage without starting another oral PrEP agent, or do something else?
So you can get CAB?
Assuming you can get CAB, which actually you can. Okay, so it looks like about almost 70% would start oral CAB while investing in coverage. That's what we did in this situation. The patient really didn't want to try another tenofovir-based regimen given the reaction that he had previously, but did want to stay on some coverage while we were waiting, figuring out insurance issues. So I just wanted to review the guidance for covering missed visits. This is per the FDA label. There's also alternatives I'll talk about. So just to review the injection schedule for CAB-LA, there's a loading dose at 0 and 4 weeks, followed by maintenance dosing every 8 weeks. So if someone knows ahead of time that they're going to have a delayed injection for more than a week delay, the label recommends bridging for up to 2 months with 30 milligrams of daily oral CAB. They say if it's longer than that period, you can, an alternative would be to do daily oral PrEP with a tenofovir-based regimen. An alternative, which many people do, is just providing an oral PrEP prescription, either tenofovir, TDF-FTC or TAF-FTC. You can even do it at the time that you're starting them on injectables as a potential bridge, and even if it's a shorter interval. And so that's a perfectly fine alternative if people are able to take a TDF-based regimen. If it's an unplanned missed injection and they come in, then you want to go ahead and administer the CAB-LA as soon as possible, assuming that they want to continue. And if it's a missed injection more than 4 weeks late, it's important to note they recommend reloading with an initial 4-week interval and then returning to the every 8-week injections. Now, unfortunately, we have seen a number of cases where people have had insurance barriers to either starting or continuing on Apretude or CAB-LA. This actually has been most prominent in people who have private or commercial insurance. There's often a complex process to go through to get approval. And then people sometimes have very high copays or out-of-pocket expenses. Also, as in this case, we've seen people's insurance status changes over time and sometimes frequently, which can interrupt their access to CAB-LA. So as part of a CFAR-funded project across several counties, we're trying to develop some tools to help providers. One of these is this insurance flow sheet that kind of is a roadmap of the process to get coverage for people who are uninsured, people who have Medi-Cal, and people who have private insurance. And we tried to highlight several pharmacies in the Bay Area that have experience working with Apretude. At the bottom, I wanted to highlight there are the field reimbursement managers for Northern California that are actually really helpful resource to work through insurance challenges. Now, in August of this year, the U.S. Preventive Task Force came out with a new recommendation statement around PrEP. This is updating their 2019 guidance, and it included some of the new PrEP regimens, including an injectable CAB. And based on a systematic review, PrEP remains a grade A recommendation, which means that there's high certainty of substantial benefit. And based on this recommendation, most private insurance plans, as well as Medicaid expansion plans, are required to cover PrEP under mandate from the Affordable Care Act. Now, unfortunately, last year in 2022, a Texas District Court judge ruled in favor of a religious organization that brought a lawsuit challenging the mandate and basically challenging the requirement that that insurance companies cover preventative services recommended by the USPSTF. Now, the US government is appealing this case. It's currently under administrative stay, but if this ruling actually goes through, it could actually jeopardize access to PrEP for many, many people, especially people who are low income. So that's something definitely to watch. So some takeaways, missed CAB-LA injections can occur either due to insurance lapses, other life circumstances, and should be anticipated. You can consider providing a prescription for oral TDF-FTC or TAF-FTC upfront for gaps, or bridge short-term with oral CAB. And pharmacists, as well as your field reimbursement managers, can actually be quite helpful in assisting with insurance challenges. Yeah.
Question from the chat is, I think I have this right. Someone asked, are you still within 7 days of target injection date? And I'm wondering whether they're curious about coverage for oral CAB if you're longer than 7 days out.
Yeah, if you're within the 7 days, then you don't need to cover. But in this case, they were already towards the end of that window, and then it was a delay to get the injectable. We had to go through the patient assistance program. They had to check all the insurance. It took several weeks, and so in that case, we wanted to cover. So case 4 is another case of delayed CAB-LA injection. This is a 42-year-old man who has sex with men, who is also experiencing homelessness, uses meth, and engages in sex work. He's had trouble taking oral PrEP. His medications have been stolen in the past. He also says he has trouble remembering taking pills. So he was offered injectable PrEP, was excited about that, started CAB-LA. With mild injection site pain. However, he missed a second injection visit and was actually unable to be located for a while. But then he drops in 2 months later and is interested in getting CAB-LA, resuming CAB-LA. So in the situation of a delay of or a over 2 month late injection, what would you do next? Would you go ahead and administer the CAB-LA while waiting for the fortune and viral load testing? Would you first get a rapid test, and if negative, then give CAB-LA while waiting for the fortune and viral load? Would you first send the fortune and viral load, then wait for the fortune results, and if negative, administer CAB-LA? Or finally, would you send both the fortune and viral load, wait for both test results to come back, and if negative, administer CAB-LA, or something else? Okay, we'll give it another minute. Okay, interesting. So we see some responses across the board. About 40% would be okay with getting a negative rapid and then go ahead and giving the injection. 33%, about a third, would want fourth gen results back. About 17% would want the viral load back, and then 11% would just go ahead and administer the CAB-LA. So what do we know about HIV infection in the setting of CAB-LA? So in HBTN-083, which was the large efficacy trial of CAB versus TDF-FTC, there were over 2,000 participants who received CAB-LA in that study, and there were only 6 cases of HIV breakthrough infections despite on-time injections in the study. So that was quite rare. However, we did see more cases of incident infections, 19 incident infections after delayed injection or no recent CAB exposure within the last 6 months. And then there was 9 additional infections at other times. So we are seeing quite commonly that HIV rapid tests and antigen antibody tests often fail to detect HIV infection in the setting of CAB-LA PrEP. In 083, this occurred in over half of the CAB arm infections. Additionally, viral suppression and delayed or diminished antibody expression can actually persist for months after infection, even after infections are discontinued. We're also learning that the risk of developing INSTI resistance is highest when HIV detection occurs within 6 months of the last CAB injection. And in fact, 10 out of 18 cases developed INSTI resistance when CAB was administered within 6 months of the first HIV visit, in which just rapid and antigen antibody tests were done. And so when they looked at retrospective testing, including HIV RNA testing, that in most cases was able to detect infection before INSTI resistance. Now, so far, we have not seen cases of developing INSTI resistance in cases where CAB was administered over 6 months from the time of the first HIV positive test, which is reassuring, and we'll be getting more data. So at this year's CROI, Sue Eshelman described a new paradigm for infections that occur in the setting of potent long-acting PrEP. And she termed this the Levi syndrome, the long-acting early viral inhibition. And she compared it to the case of acute HIV infection that occurs naturally. So this is shown, acute HIV is on the left, Levi's on the right. And you can see with acute HIV infection, viral replication is generally explosive. People are generally symptomatic with high viral loads, whereas on the in the Levi syndrome, viral replication is really smoldering. And often people have minimal symptoms. They can have low or undetectable RNA. And they can actually have assay reversion, where the test is initially reactive and then comes back negative, and then when repeated, and then can become positive again. And this pattern can actually go on for months. So in this case of delayed, or in this case, highlights a couple takeaways. Detection of infection in the setting of CAB-LA can often be delayed using rapid and antigen antibody tests for screening. The current FDA prescribing information and CDC guidance do recommend HIV screening during CAB-LA PrEP. This actually is not in the WHO guidelines, and it's currently being evaluated prospectively in HPTN 083 and 084 open label extension studies. So we'll have more data coming on this. In the setting of delayed injection, given this Levi syndrome and possibly missing infections, it is recommended getting HIV RNA prior to starting re-injections. I do want to highlight the SeroPrep study, which Kate Koss and Monica Gandhi are leading here at UCSF, and also Urvi Parekh at the University of Pittsburgh. This is a study of people who have evidence of HIV infection and have either CAB exposure within the last 18 months or oral PrEP exposure within the last 3 months. And they're doing sensitive diagnostics, resistance testing, and PK testing in these individuals, and also following outcomes on HIV treatment. And this is a nationwide study. People can either provide samples from home or from the clinic. So it's a great resource in this setting. I want to move on to our last case, which is PrEP in pregnancy. This is a 35-year-old cisgender. Yeah.
I'm so sorry. Do you mind if I ask
Yeah.
a couple of questions from
Yeah.
the chat? Sorry, I'm just going to come up here. One, which is, could you administer Cabril while waiting for acute labs and switch back to Cab when confirmed negative? What do you think about that?
That's an interesting approach. I think that could be considered if you are worried but people want to stay on PrEP. Another option also is, if people want to do oral PrEP during that period and wait, and then as you get the results back, that could be another strategy.
I'll let you finish this case, but a question for you and Hyman to think about. Someone asked, where are we with TAF 211? So I'll leave that as a teaser and you come back to that.
Great. Case 5 is a case of PrEP in pregnancy. This is a 35-year-old cisgender woman with multiple sexual partners who actually had not heard of PrEP before, but when learning about PrEP was excited to hear about it during a clinic visit. She was especially excited about injectable PrEP, saying, I did not know we had advanced that much in medicine, that you could protect yourself from HIV without taking a daily pill. And they were started on CAB-LA, received 2 injections at 0 and 1 months, and tolerating well. At the 3-month visit, her urine pregnancy test comes back positive. So she expresses interest in continuing the pregnancy and asks whether it's safe or to continue injectable PrEP. So the questions are, what would you recommend in this patient? Would you continue CAB-LA injections? switch to daily oral TDF-FTC, switch to daily oral TAF-FTC, stop PrEP and advise her to use other protective measures or something else. Okay, so it looks like half would continue CAB-LA, about 42% would switch to an oral TDF-FTC regimen, and 8% said something else. So there have been a number of studies that have demonstrated that during pregnancy and postpartum period, there is an increased risk of HIV acquisition. This risk increases during pregnancy, so that in late pregnancy and the postpartum period, the risk is actually 3 to 4-fold higher. And this is thought to be due to biological changes during pregnancy and the postpartum period that increases HIV susceptibility. So what do we know about the risk of or the safety of CAB-LA during pregnancy? Sinead Delaney-Moretway at CROI last year presented data from HBTN 084, which was a large efficacy trial of TDF-FTC versus CAB in African women, over 3,000 women. And in that study, if someone was diagnosed with pregnancy, they were told to stop CAB-LA and were offered to switch to TDF-FTC in that study. So at the time of this presentation, there were about 57 pregnancies detected, 7 in the oral lead-in phase and 50 during the injection phase. The median gestational age of pregnancy was 7 weeks, and there was a median of 6 injections administered prior to pregnancy. And so they looked at maternal outcomes, pregnancy outcomes, and infant outcomes. Here you can see the maternal outcomes comparing the 2 arms. And across various outcomes, they were very similar between CAB-LA and TDF-FTC. And looking at pregnancy outcomes, similarly, the outcomes were similar with no congenital anomalies in either arm. And then looking at infant outcomes, such as infant size, and small for gestational age, these were also similar across arms. They also looked at terminal PK of cabotegravir in pregnancy after injection discontinuation. And so on the left, we're looking at CAB concentrations after discontinuation during pregnancy. And you can see that they persist at quite substantial levels for over a year after the first positive pregnancy date. On the right side, we're looking at the half-life of cabotegravir in pregnant versus non-pregnant women, and you can see that they're also quite similar, which is reassuring. So some takeaways of pregnancy on CAB-LA. From the data, preliminary data from HBTN 084, residual CAB-LA generally is well tolerated during pregnancy. There were no congenital anomalies noted. Residual CAB exposures last through pregnancy, which actually may make the benefit of stopping PrEP less clear because the levels are going to be there throughout pregnancy. And then drug concentrations were comparable in pregnant versus non-pregnant women. Now, the HBTN 084 open label extension is now allowing women to continue CAB during pregnancy, delivery, and lactation. And so there are about 150 participants who are actively dosing in pregnancy during the study. And they have over 400 women who have had perinatal exposure to CAB. So we are going to get more data on this. At the moment, it is recommended that a risk-benefit discussion is held about continuing PrEP and also which option to continue so that users can make an informed choice. We do have more safety data on TDF-FTC during pregnancy. It's category B, and there have been several systematic reviews that have been done which have not identified any significant safety concerns. The other recommendation is to register patients in the antiretroviral pregnancy registry so that we can continue to collect data. So I just wanted to summarize across both of our talks that it's important to discuss PrEP with sexually active adults and adolescents and people who inject drugs, as well as those who use substances. You want to offer all available PrEP options that may be appropriate using a shared decision-making approach. More important to consider comorbidities, including renal disease, bone disease, cardiovascular risk factors when counseling about the different PrEP options. You want to anticipate missed CAB-LA injections and offer oral PrEP and one of these regimens as a bridging regimen. Detection of HIV infections often delayed in the setting of CAB-LA, and it's recommended if there is a significant delay for HIV RNA test results. And finally, PrEP can be continued through pregnancy based on a risk-benefit discussion and recognizing the increased susceptibility during pregnancy and postpartum, and recommend using a shared decision-making approach on choosing the medication. So I just want to acknowledge several people who contributed data, shared their slides, and also gave feedback on the presentation, as well as the study participants who took part in the various trials.
Thank you both so much for a fantastic talk. I'm curious if there are any questions from the audience, and while people are thinking, I see a couple. I may have you respond to that initial question from the chat. What are your thoughts about TAF 211?
Yeah, it's a great question. We actually get that question a lot. There aren't official data that have studied TAF FDC as a 211 regimen. Based on the PK, what we know about it, given that intracellular levels of tenofovir are quite high quickly, that it is likely to work. I think there are actually studies looking at different dosing regimens right now with TAF FTC, so hopefully we will have more data.
Yeah, I had a little bit of a question and a comment, I guess, about case 4. So the participant who is coming late for the CAB injection and really wants to continue to restart CAB, I sort of don't see the rationale for, well, one, I don't think I would do CAB-RIL in that scenario in case there was resistance, but you know, if you order the viral load stat, the antigen antibody stat, you're going to get those results so quickly. And if the person is at high risk of HIV and won't take the oral TDF-FTC, I sort of think the risk benefit might be in favor of administering the CAB-LA, and then assuming you can find the participant after you administer it, adding, you know, Simtuza or something if they happened in that low probability that they happen to be positive. I don't know what you think about that approach or how Hyman feels.
So yeah, I agree. I think so. One of the comments was around using cabotegravir or Cabenuva essentially, and I think that, you know, if you had an indication for a post-exposure prophylaxis, you would give them a post-exposure prophylaxis regimen, but I wouldn't give CAB-RIL. I think part of it is a context for the case where someone has you know, been in care and then out of care. And I think that, you know, you could potentially be giving an injection to someone, and then if they don't come back and actually do have HIV, then you might, you know, those are the scenarios in which we really drove INSTI resistance. So I think it would be a risk-benefit discussion with the participant, and I think, or the patient, you could definitely make a decision. I think the sort of more conservative thing to do would be to have those test results available to ensure that they haven't acquired HIV in the time at which they were out of sort of care.
Thanks, those are great cases. In the ultra-sensitive RNA, what can you describe that a little more? What would that exactly be? Would that be like a single copy assay, or are we talking about, how could you define that a little bit better, please?
Yeah,
It was just standard testing. It was nothing more than you do in clinical care. Yeah, so what, 20 or 40, whatever the cutoff is in the lab.
Great. Any other questions?
Thank you both for a great talk. I was curious about availability of post-exposure prophylaxis and interest in it and demand for it, and also just those disparities. Curious about sort of actions being taken from your point of view that are effective to address some of those disparities that are really quite stark. Thanks.
Thank you for bringing up PrEP. It's often overlooked, and so I think as part of our Getting to Zero, we are incorporating both PrEP and PEP promotion in our activities. I think PEP is often also a great option for people who, initially have an exposure and haven't tried PEP before. It's a way just to kind of get on the regimen, and then often people switch from or transition seamlessly from PEP to PrEP. So I think that is a really good option and is underutilized.
I agree that, PEP is an important part of our prevention toolkit, but also we have to be realistic about what the limitations are. So in the PROUD study where, they looked at delayed and immediate PrEP initiation and delayed arm, about 30% of people use PrEP and their incidence was still 9%. So it was, there was a lot of PEP used in that group, and there was still a lot of HIV diagnoses because people weren't coming in, for all of the potential exposures that they had. So I think that's where, it's really important to use it and also leverage it potentially as a bridge to PrEP. And I'm not sure about your second question because things are getting worse, not better. I think that in places where low barrier access is available, where a lot of the system structures are removed. So I know that DC had a really good sort of red carpet type of program where, really going out of your way to help people. During the Mpox outbreak, we took a strategy at Strut where we actually prioritize African-American Latinx individuals to receive the vaccination. And that was somewhat successful, I think, but I think it's going to take it's not just going to happen on its own. It's going to take an active effort to ensure that we remove barriers, including cost, providers, and systematic issues that are standing in people's way. We have a PrEP desert in the Bayview. And so there are other systematic things, even in our own city, that are driving some of the disparities that we're seeing that are bigger than just sort of offering PrEP to people when they can't travel, they have food insecurity, struggling with, being unhoused, and all those other barriers that are driving it.
Thank you. Question from the chat about any info on when MPT, such as an oral contraceptive plus TDF-FTC, might become available. I can't say I know what MTP stands for. MPT stands for.
Yeah, so I think that's referring to multi-purpose prevention technology, which is combining either PrEP with oral contraception or prevention against multiple different STIs, including bacterial STIs or even herpes. And so it is a really robust field of investigation. And there are multiple different formulations that are being looked at. There's a combination pill that has PrEP and oral contraceptives that's currently being looked at within the HIV Prevention Trials Network. There's also implants, as well as vaginal rings and other modalities that are currently being investigated to increase the options. And there is data that people really like MPTs and that they can potentially increase uptake of these strategies.
Someone also commented, add doxypep to that.
Yes.
I'll just say that, there are a couple of great comments in the chat, I think echoing Matt's point, a couple questions around, yes, I think that you covered regarding administering Cabril while waiting for acute lapse. Would you be concerned about NST resistance or NNRTI resistance? If you think there's anything else that you'd like to add, feel free, but I think we've covered it. Okay. Fantastic. Any other last questions? Great. Thank you both so much. Thank you.